Febrile child. Key points. Febrile neonates less than or equal to 28 days of corrected age require investigations, FBE, CRP, blood, urine, and CSF cultures plus or minus CXR, and empiric. 4. Antibiotic therapy. In febrile infants and GT 28 days of corrected age and LT 3 months, have a low threshold for investigation and treatment based on clinical appearance and presence, or absence, of a clinically obvious focus. In infants and LT 3 months of age, hypothermia or temperature instability can be signs of serious bacterial infection, or other illness. The severity of illness cannot be predicted by the degree of fever, its rapidity of onset, its response to antipyretics or the presence of febrile seizures. The appearance of the child is the most useful indicator. Background. Definition of fever: body temperature and GT 38.0 degrees Celsius. Where possible, use the same body site and the same type of thermometer when measuring temperatures. See additional notes below. The most common causes of fever in children are viral infections. However, serious bacterial infections, SBIs, need to be considered. The most common SBIs found in children without a focus are urinary tract infections. Blank. 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 And soft tissue infections. Mastoiditis, bacteremia. Blank. Blank. Since the introduction of the pneumococcal vaccine, the rate of occult bacteremia has fallen to LT 1% in healthy, immunized children. Blank. If there is a history of COVID-19 infection. Other uncommon causes of prolonged fever in children include inflammatory, immune-mediated, and neoplastic conditions. Specialist input may be required. Assessment. History. Localizing symptoms e.g. cough, headache, photophobia, diarrhea, vomiting, abdominal pain, musculoskeletal pain, rash. Travel. Sick contacts. Immunization. Children and LT 6 months age or with incomplete immunization. Medication. Prior treatment with antibiotics may mask signs of a bacterial infection. Blank. Central line in situ. Chronic lung disease, congenital heart disease, previous invasive bacterial infections, children of Aboriginal, Torres Strait Islander, Pacific Islander or Maori origin, multiple health service presentations. Notes: teething does not cause fever. Post-vaccination fever is common, with a typical onset within 24 hours of immunization and duration up to 2 to 3 days. However, in an unwell child, fever should not be attributed to vaccination alone. Examination. Certain aspects of the child's behavior and appearance provide the best indication of whether they are at high risk of SBI. Features suggestive of an unwell child. Color: pallor, mottled, blue/cyanosed. Activity: lethargy or decreased activity. Not responding normally to social cues. Does not wake or only with prolonged stimulation, or if roused, does not stay awake. Weak, high-pitched, or continuous cry. Respiratory: grunting, tachypnoea, increased work of breathing, hypoxia, circulation and hydration. Poor feeding, dry mucous membranes, persistent tachycardia, central capillary refill time greater than or equal to 3 seconds, reduced skin turgor, reduced urine output. Neurological: bulging fontanelle, excessive irritability, neck stiffness. Focal neurological signs: focal, complex, or prolonged seizures. Other: non-blanching rash, fever for greater than or equal to 5 days, swelling of a limb or joint, non-weight-bearing/not using an extremity. Adapted from Feverish Illness in Children. Blank. The child should be examined for a clinical focus of infection. Remove clothing as required to complete a full examination, looking for subtle signs. Management. Blank. Irrespective of the degree of fever, do not accept apparent otitis media or upper respiratory symptoms as the source of infection in young infants or unwell children. These children still require assessment for possible SBI. If the child is stable, it is preferable to complete investigations looking for an infective focus before commencing antibiotics. In children from high-risk groups, have a lower threshold for investigations. UTI is the most common SBI. If there is no clinically obvious focus for fever, urine collection and testing should be performed. When blood cultures are indicated, ensure adequate volume collected. See additional notes below. Blank. Infants. 28 days corrected age. Blank. Blank. FBE, CRP, blood culture, urine, by spot, see section on urine collection below for other methods, LP plus or minus EXR. Prompt treatment with empiric. Blank. If the infant appears unwell, or there is likely to be a delay in completing all of the required investigations, proceed with administration of antibiotics. Infants 29 days to 3 months corrected age. Children and GT 3 months corrected age. Consider consultation with local pediatric team when unwell child, septic shock, infants and LT 28 days corrected age with fever, should be admitted for empiric antibiotics. Barriers to follow-up within 24 hours due to social or external factors, consider admission. High-risk child. Advice needed regarding empiric treatment. Prolonged fever of unclear cause. Consider transfer to tertiary center when child requiring care above the level of comfort of the local hospital. For emergency advice and pediatric or neonatal ICU transfers, call the Pediatric Infant Perinatal Emergency Retrieval, Piper Service. Consider discharge when infants 29 days to 3 months of corrected age, well, investigations normal, discussed with senior doctor, follow-up within 12 to hours has been arranged. Children and GT 3 months corrected age, well, follow-up has been arranged. Always advise parents to return for review if the child is deteriorating. Additional notes. Temperature. Measurements. Axillary temperature, recommended for infants and LT 3 months of age. For a more accurate reading, the thermometer should be placed over the axillary artery for 3 minutes. Tympanic temperature, recommended for children and GT 3 months of age. For an accurate measurement, the pinna must be to straighten the external auditory meatus and the instrument should be directed at the tympanic membrane. Skin temperature, infrared or infrared thermometers are unreliable. Rectal temperature, in neonates, screen first with axillary temperature, then consider performing a rectal temperature if a fever is still suspected. Lumbar, puncture. When indicated, LP should be performed without delay and, ideally, before the administration of antibiotics. Contraindications to LP include impaired conscious state, focal neurological signs, impaired coagulation, or hemodynamic instability. In this circumstance, treatment for meningitis/encephalitis should be commenced and an LP performed when the child is stable, and there are no contraindications. C. Blank. Urine collection. Bag urine specimens should never be sent for culture. Due to high false positive rates, contamination rate 50%. Suprapubic ASPI rate, C. In/out catheter, standard, gold. Standard, contamination rate 1%. In/out catheter, useful if there is little urine in the bladder, such as after failed clean catch or spa, discard first few drops of urine if possible to reduce contamination rate 10%. Midstream urine, MSU preferred method for toilet-trained children who can void on request, contamination rate 25%. Clean catch, appropriate for precontinent children who cannot void on request, but are not seriously unwell, yield may be blank. Blank. Contamination rate 25%. The perineal/genital area should be cleaned with saline-soaked gauze for 10 seconds before collecting midstream or clean catch urine. Blood culture. Blood cultures should be taken using an aseptic technique and sterile gloves. Accuracy of blood culture results rely on correct blood volume to improve detection of bacteremia or fungemia. Inoculate aerobic bottle preferentially, i.e. if inadequate volume for both bottles. Volume and type of blood culture. Weight. Pediatric aerobic bottle. Adult aerobic bottle. Adult anaerobic bottle. For small volumes. Pediatric aerobic bottle.